You're back. Hallelujah. Okay. Thank you, Kevin.
You're welcome.
Whew.
All right, welcome back, Nell. I was just saying welcome everybody to our virtual office hours, the Appalachian Diabetes Network. Today's guest speaker will be Nell Stuart. And the topic, as you can see on the screen, there's going to be the progressive nature of type 2 diabetes. So before we get started with our presentation today, we always like to go around and do short introductions. So if you could tell us your name, your coalition, and what type of animal you have at your house, if you have a cat, dog, or a bunny rabbit, if you have any pets.
Are you going to call on people?
Nope, I want people to volunteer.
I'll volunteer.
Good morning. I'm Sharon Haynes with Coosa County. I'm with the New Leaf Coalition, and I have a cane corso at my house.
Oh, is that a dog? Cane
Yes, it is. It's a huge dog.
Welcome, Sharon. Thank you.
I want to see him, but I know we don't have time for that. So carry on.
Hi, I'm Sue Basta from Adams and Brown counties in Ohio, and I have two-year-old full sister beagle types, Annie and Nellie.
Aw.
Nellie. People name their dogs after me all the time.
Hi, I'm Mary Beth Castle. I'm with the Johnson County Health Department in Kentucky. I am a member of the Johnson County Health Coalition, as well as the Big Sandy Diabetes Coalition. And I have 3 Australian cattle dogs, and I also have several head of cattle. I live on a farm.
Wow.
Thank you.
You're welcome.
Okay, I guess I'll go. My name is Faye Hall Jackson, and I am in Tuskegee-Macon County Coalition. And I'm not really an animal person because I kind of grew up in the country on a farm, but my husband and my son have a Rottweiler.
Okay. Faye, welcome.
Thank you.
Amanda Yergin with the Bledsoe County Diabetes Coalition, and we have 5 dogs. Too many.
Thanks, Amanda.
Janet Coward with the Lake Cumberland District Health Department, and I have 1 cat and 1 dog.
Thanks, Janet. Welcome.
I'm Vicki with Lake Cumberland District Health Department, and I have 1 dog, and I have stray cats that come and visit us all the time. So I know I have at least 2 of those, maybe more at this point. But
Thanks, Vicki. If you keep feeding them, they'll keep coming.
that's what I keep telling my husband, and he just says, okay.
Welcome. I'm going to start calling on people.
Hey, this is Kevin Simpson. I'm with Marshall University IT, and this is Ozzy. He is our only dog, but we also have 5 birds, a cockatiel, and 4 parakeets.
Mercy, Kevin.
Ozzy's so cute.
Yes, he is. And he's the big baby.
How about Malika from Mississippi?
I just saw her unmute herself, I thought, but I can't hear her.
Then we have a phone number, 423-645. If that's your phone number, if you can unmute.
That phone number may be Jan Frechette. She's with Bledsoe County Health Coalition. She sent me a message saying that she's having a hard time with her mic. So,
Okay, well, you can also use the chat box if you're unable to work your audio. That's always an option.
Yeah, another key component is there is a button for you to choose join audio, computer audio. That might be part of it. If you're using a phone only on Zoom, there is, it's called use internet audio. If you might have just ignored that message, and you might have to hang up and join again to get that button again, especially on a phone using an app. So just a couple little hints there.
All right, and I'm Regina Knox, Marshall University, and my son has a pit bull, so that I guess we share him. I don't really like him.
Do you feed him, Regina? If so, you share him.
Nope, I give him water when he's outside.
I'm Nell, and I have 2 cats. One is total white, and we get him shaved for the summer, and Regina says he's naked. So
He is.
but he looks better now. It's growing in just a little, but we don't want it to grow in too much because it's hot outside.
All right.
I'm Deborah Cox, Estill County, Kentucky Diabetes Coalition. I have 4 beagles, 2 cats at the house, and some barn cats, and I feed most of them.
But no mice because of the barn cats.
Oh well, despite all the cats, they're still mice.
Okay.
Well, welcome and thank you. And then Malika put something in the chat box. She's from Kemper County, Mississippi. And they have cows also, cows, horses, goats, and they just added 2 dogs.
Mercy. I think 2 cats are hard enough to take care of.
All right, and if we don't have any other introductions, we will go ahead and get started. And I will turn it over to our illustrious speaker of the moment, of the hour. I present to you some, I introduce to you others, Nell Stuart.
Okay. Very nice, Regina. And I just want to make sure everybody can see the slides. I can see them. Can it just nod your head if you can see the slides? I realize if you're on the phone, you may not be able to see the slides. Okay, this is going to be, basically, we're going to concentrate on one thing only, but I'm going to do a couple of things leading up to my major point. So this is not all about diabetes. It's just one point that I want to get out there and see where it leads us and go from there. So Regina, if you would go to the next slide, please. So I want to brainstorm, and we'll take about, I got to look at the time, maybe about 5 minutes of brainstorming. We don't want to take too long, but go to the next slide. Here's my question to people. Why do people resist using an injectable to manage their diabetes? I've been a diabetes educator for a long time, and I've been in a lot of different areas, whether I'm calling on doctors or working with patients or talking to coalitions. And I would just like the people on this call to just say one thing that comes to mind about why you think people resist taking an injectable to manage their diabetes.
Fear.
Fear, okay.
Pain.
Pain, okay. Anything else?
I think
Maybe they
maybe
think it's too difficult.
Mm-hmm. Okay, too difficult.
I think maybe some people might view it as an indication that they've failed,
Okay.
you know, with other things, and now they've got to go to the needle.
Okay. Yep.
Sort of agree with Sue. I had a patient blame themselves. It's almost like they were shaming themselves.
Yep.
I think people see themselves as once they go to injectables that they're going to be on them forever, and there's like the beginning of the end.
Mm-hmm. Those are very good answers. Anybody have one that's totally different than that, just so we don't leave anybody out?
I wonder if some people might be concerned that it might be more expensive, you know, the expense of the equipment in addition to the medication.
Uh-huh. Okay, those are all very good answers. And this is not going to be a situation where I'm going to show people things to try to convince them that it doesn't have to be painful, though we could do that. And I love doing that kind of thing. And it's not going to be a time that I'm going to try to convince a doctor that he needs to prescribe injectables. What I want to do is get just a couple of pieces of information out there to you guys and see what you think. So next slide, Regina. So we're gonna think in a slightly different way. Those of you who came to my talk in, where were we? Gatlinburg, have already seen part of this, so you know you can just doze off if you don't want to see it again. But the rest of you must pay attention. So next slide. So I have 2 slides now where I'm going to ask a couple of questions, and we will answer them after we get to my main slide and I go through a couple of things. So I want you to consider something. What's going on in a person's body who is going to get type 2 diabetes, whether they know it or not? They probably don't know it, but what's going on in their body 10 to 15 years prior to getting diabetes, and what would you tell them to do? And then next slide, Regina. What is going on in a person's body who's had diabetes for 20 years or longer? And what would you then recommend to this person? So next slide, and we're going to get to the one that we're going to spend some time on. So it's easier if I can point to things on this, but I can do it without pointing. You all just need to look at the slide and notice that there is a dotted line going from the top to the bottom, or from the bottom to the top. And at the bottom of that line, it says 0. So when you look across where it says 0, to the left, it's -5, -10, -15. That's 15 years before the diagnosis of diabetes. If you go to the right of the 0, we go out 5, 10, 15, 20, 25, 30 years after the diagnosis of diabetes. So this is a timeline, and I want to talk about what's going on in the body during all this time. Are there any questions so far? Because it can be confusing if you don't get on at the beginning. Any questions about it's a timeline? So that 0 is the onset of diabetes. So that's if somebody walked into a doctor's office and the blood sugar, the fasting blood sugar was 126 or higher, and the doctor said, okay, you have diabetes. That's what that line is. So at the very top, where it says glucose on the left, and we have 2 lines. We've got a gold line and we've got a red line. The gold line is labeled post-meal glucose. And then the red line is the fasting glucose. So notice that 15 years before diagnosis, over there in the pre-diabetes range, blood sugars are pretty normal, right? The post-meal glucose is not going up, the fasting glucose not going up. But when we get toward about 7 years or so before the diagnosis of diabetes, the post-meal glucose starts going up and even gets higher than normal, higher than what it should be. But the fasting blood sugar is not higher than normal. We diagnose diabetes with a fasting blood sugar, so when it gets over that, when it gets to 126 or higher, that's a diagnosis. So, but before that, the post-meal blood sugars are going up. Any questions so far? Let's go to the bottom screen then. And we've got 4 lines there. So let's walk through those. The top neon blue line is called insulin resistance. And that just means that the cells in your body, particularly the cells, the skeletal muscle cells, are refusing to let the circulating insulin do its job. That's called insulin resistance. And notice that that insulin resistance starts about 15 years before the diagnosis of type 2 diabetes. Now, that doesn't mean your blood sugar starts going high, because what happens, the next line is the insulin level. So your insulin, your body starts making extra insulin and just starts pumping it out to overcome this resistance. And that works pretty well until a few years goes by, and you'll notice at the top when the post-meal glucose is going up, that's when the insulin level is kind of coming down, because the body just cannot keep up with this insulin resistance and the demand for more and more insulin. Anybody have a question so far? Okay. I can only see a few heads, but I'm going to go with the heads I can see that there's no questions. So if you do have a question, just unmute yourself and ask me. Now let's look at the bottom purple line that's called beta cell function. I realize I'm talking to the choir here. I don't know the background of everybody on this call, but the beta cells are those cells in your pancreas that make insulin. And they start dying off about 15 years before the diagnosis of diabetes. So as you can see, that purple line just keeps going down. And when you're diagnosed with diabetes, not that you've had it for years and years, but you just got diagnosed, only about half of them are still alive and working. Now, do you have any questions? Is there anybody who is shocked by that information?
I'm a little shocked, because if they're dying, how come people are not diagnosed earlier? Is that the pre-diabetes phase? If only half of them are left.
Well, they're dying off, but the ones that are still alive are still functioning, and they're still pumping out as much insulin as they can, and probably more than they should be. So they're working very hard. So we can go into more of that, Regina, if we have time. But I just want you to know what's going on in the body during this time. And then look at we have one last line to discuss for a second, and that's the green one that's called the incretin effect. That's another hormone. We have an insulin hormone, and we have the incretin hormones in the body. And from the same time the beta cell function is going down, the incretin hormones are also going down. So less and less incretin is made, which is a very important hormone in type 2 diabetes. So those of you who are probably thinking, what the heck is an incretin hormone? One of the ones that we know about and have injectables for today are called GLP-1s. And if you haven't heard of that, because it just doesn't come off the tongue like insulin does, we're talking about Victoza, Ozempic, Trulicity. That's a GLP-1. So to recap here, 15 years before the diagnosis of diabetes, people are starting into that insulin resistance phase. And a few years down the road, blood sugars will start to go up. But at the beginning, there's just insulin resistance and a high insulin level circulating in the body. So at this stage, we can make a huge difference in the person's life by simply saying, let's get them into a national diabetes prevention program, or if they have not been diagnosed with with prediabetes, but they are at risk either because of their age, because of their weight, various and sundry other things we could go through. Lifestyle modification is going to make a huge effect. It's going to just be awesome. So if we can get them to lose just a little bit of weight and do a little bit more exercise, they may be able to get that insulin resistance a little bit help so that the beta cells don't have to fight so hard, and maybe prevent diabetes, or at least keep it from happening as soon as it would have. So that's a huge takeaway here. There's a lot we can do with lifestyle modification. Now keep looking at that slide and go over to say 10, 20, 25 years that they've had diabetes. Notice that the insulin resistance situation never goes away. The insulin level goes down. The GLP-1 or incretin levels go down. The beta cell is virtually non-functioning. At this point, my question to you guys is, if all you do is say to the person at that stage whose blood sugars are too high, you must exercise more, you must eat less, are you going to be effective in blessing this person? Or are you just going to frustrate them because they can't seem to get that done? Or they are doing what you said, but it's not working. So this is the dichotomy that I wanted to point out, because I have run into this for literally decades, where somebody who's had diabetes for 25 years is maybe on several injectables and their blood sugars are still too high. The doctors are not following up. They're not adding, they're not getting them on the right dose. The patient doesn't understand. So they're on some like ridiculously low dose of insulin, or maybe they just gave up and stopped taking it altogether. So as you can see, it matters where this person is. And why did we decide to talk about injectables? Because injectables seem to be a barrier to people. They also, in my last 7 years with Novo Nordisk, and I was calling on doctors, they're a barrier to doctors. A lot of doctors don't want to deal with injectables. A lot of doctors are scared of diabetes. They don't understand it. Primary care docs have a lot on their plate. I mean, right now they've got COVID-19 on their plate. I can't imagine what they're doing with the diabetes patients, but I'm not involved in that at the moment. So it's a struggle. But I want you to know that a patient that's in this situation who is either on or not on an injectable at 25 years, if their blood sugar is out of control, the worst thing you can do is yell at them for not eating well. They're going to tell you that they're hungry all the time, and you're going to try to say, well, that's impossible. You eat all the time. No, they're hungry all the time because they're not getting the nourishment into the cells, and the cells, there's another slide I could do another time, but things are going on in the brain saying, hey, the sugar is staying in the blood and it's not getting into the cells. Therefore, we're going to make you hungrier so that you'll eat something so that we can get this done. So it's a spiral downward. And if all we do in the community level is tell people who've had diabetes for 20 years that they need to eat better and exercise more, but their blood sugars are still not in control, we need another message for these people. Get back to your doctor. So my idea is to have a seminar where I can come teach lay people, what do you do in this situation? They don't have to be nurses. They don't have to understand every diabetes medication, but I think they need a little step beyond just exercise and stop eating so much, lose some weight. So what do you think so far? I'm sure somebody has a question. And I want one or two people, shy people. I think I saw Faye with her hand up. Okay, Faye.
I'm raising my hand.
Okay.
So because I am completely the lay person here, I am not really clear on what the end game is. So I'm looking at the bottom slide here, the relative amount with the insulin levels, B cell function, and incretin, I think you said, effect.
Yeah.
So if this insulin resistance, it almost sounds like no matter what I'm doing, my insulin resistance is not really going to quite change here. What is the end goal? What am I speaking to the people as the goal in diabetes education? So
Okay. Okay. So that's a very good question. And because I'm trying to, get all of this stuff out in quick, I did leave a few thousand things out. But the end goal, first of all, is that everybody with type 2 diabetes have a very well-controlled blood sugar throughout their whole history, that they never get terribly out of control. Sure, it's going to go up occasionally. Let's say you're on all the right medications, everything is wonderful, but you get sick and you have a cold or you get the flu, hopefully not the COVID, but your blood sugar is going to go up and probably be a little out of control during that time, because that does happen. But what we want is that for 75% of the time, we want blood sugars in the range that is considered normal for type 2 diabetes, so that we don't progress to the long-term complications. And that is possible. So it is a progressive disease, meaning that it's going to need more and more drugs over time, or a change, but it doesn't need to lead to the long-term complications of diabetes. So the end goal is no complications and good blood sugars and feeling great for the rest of your life. That's the end goal. Now, why are we not getting there? I mean, you all know that there's a lot of people who just won't do what you ask them to do. I mean, that's true for everything. But part of it is this lack of information, that at some point, people who have type 2 diabetes, if they live long enough, are going to need an injectable or 2 or 3. And these injectables are hormones that are natural in the body, more natural than all the pills that get thrust on them. So if we could get people to get on the incretins early on, incretins like Victoza, Ozempic, Trulicity, these particular injectables not only lower blood sugar, including they lower the post-meal blood sugar, which tends to go up early, but they make people less insulin resistant. They make people not be so hungry. They want to eat less. I mean, it's almost like the miracle drug. And they've been around long enough that more and more people can now afford them, and they're on insurances, and they're even on some of them are on Medicaid. So I think not having them to understand that if they don't get on an injectable at the time that doctor has recommended it, they're probably going to be fighting a losing battle. Does that help answer the question? I realize I'm in my own little world here of, does that help, Faye?
It does.
Okay.
Thank you.
And I know there's a lot to learn. That's why I would love to do, we do a lot of stuff at Marshall, training on various things. And I would like to train on this aspect. So we had lay leaders in the community who can actually talk about this to their people in the community. Now, that's my goal. May not be everybody else's goal, but it's my goal at Marshall. Any other question? I'm just looking at the time here. Oh, we're doing
well. If you've had a problem with the physicians or the primary care providers, I know educating the consumers, maybe if they're going to their primary care providers and asking about these things might help.
Mm-hmm.
But it seems like you got to do something with the primary care providers too.
Absolutely. And I think that in every community that's going to be it's going to look differently. again, I've done that for 7 years, and I covered a territory, and that's what I was told to do. Train the primary care providers.
Right.
Some of them were
Tough.
awesome. Some of them said, I don't really want to talk to you.
It's tough.
Yeah. So, but so therefore, having done it from various levels, I thought, okay, let's get to the people who actually are in the community, who have some control in that particular community. And if enough people who have diabetes in the community know that this is important and they're no longer afraid of an injectable, they can go back to their primary care doctor and say, I really think we need to consider this because I've been talking to, or if it's simply go to diabetes care and education, what is it called? Go to all these acronyms, and I just got audited by AADE, and so I got all these acronyms in my head. But anyway, if they went to a session or two about diabetes education and they could talk to a CDE, now called something else, they might be able to talk to their doctor better. So, I mean, I have ideas, but we got to start here with this little group on this wonderful little webinar.
But you know, this is Faye again. I'm raising my hand again.
Yeah.
I am, and give me 30 seconds to let my brain catch up with my emotion right now. But I'm really thinking, even before we get to the injection pieces, I think that one of the places where our coalitions, well, I only speak for us here in Tuskegee and Macon County, one of the ways that we can perhaps be a little bit more relevant is just in sharing, breaking down this slide right here to the folks in our diabetes support group, because all we really hear is controlling insulin. Don't really hear too much about pancreatic functions, metabolic pathways, and if there could truly be some lay level messaging that could really help us to help our communities speak the words, then from the groundswell, we could then better educate our constituencies to ask the right questions of the professional primary provider.
You are right on my wavelength, Faye. I think we're speaking the exact same language, and Sheila and I had a long conversation a couple of weeks ago because there was some funding offered and we were supposed to come up with an idea. And of course, this is my passion anyway. And we got to talking, and she said, because she's been with the Diabetes Coalitions for 20 years and knows all of you very well, she said that she thought that we could do something where we did go to what you said, the diabetes support groups, and maybe even help the support groups if they're not functioning, but helping get them functioning again and do this kind of thing. So we got all excited about the idea. So I'm going to tell Sheila, who's not on this call today, that you are right in our pathway of thinking. And if we need to brainstorm some more, we'll come to Mississippi and brainstorm with you.
Well, I'll be in Alabama, but it's okay.
Alabama. Okay, sorry. It's all Southern to me.
Accent, any accent. Okay, I'm going back on mute.
Oh my goodness. Okay. So we can come back to this slide, but go on to the next slide, Regina, so that we can wrap up, and then we can talk as long as anybody wants us to. And then you'll have to hit it again. So just some takeaway messages from what I've said. And if you'll hit it again, something will come up, Regina.
Okay, there's a comment in the chat box.
Okay.
Healthcare providers seem reluctant to order A1C tests on people who have a BMI above 25. People's weight fluctuates during a year. I don't know if insurance companies are reluctant to pay for A1C tests or not.
So that's interesting. Okay, I haven't run into that. I can't even address that. I do know that some people are not getting A1Cs, but there's documentation about who should be getting an A1C and when. We could maybe get that information out so that you could use that to whenever appropriate, because there are standards of care that tell doctors when it's appropriate to order an A1C. So are you taking notes, Regina? It looks like you are.
Yes.
So I figured you're writing this down so I don't have to. Okay.
Yes.
Okay. I probably have it somewhere on my computer. Okay, so takeaway messages. Diabetes doesn't cause complications. It's out of control diabetes that causes complications. So we need to keep that in mind. The end game is we don't want complications. So let's keep everybody out of that out of control area. At diagnosis, there's 2 hormones in the body that are declining, and we talked about that. One's insulin, which is produced by the beta cells, and the other one are the incretin hormones. So they're both declining, and my gosh, just simply putting them back in the body helps immensely. And then exercising and eating healthy cannot replace these hormones. Exercising and eating healthy do help with a lot of things. It helps with the insulin resistance. And even if you have to take an injectable or you've been on one for a long time, and let's say you start exercising and eating healthy and even lose some weight, even if you have to stay on those injectables because your body just won't make enough, the less you weigh, the less overweight you are, the less medication you'll have to take because your body doesn't have such a high demand. So the heavier you are, the more resistant your body is to its own insulin, the more you'll have to, a heavier person requires more medication, whatever medication they're on. So exercise and eating healthy is good for everybody, no matter where they are. It's just we have to stop doing just those 2 for the people who really need an additional medication. We can't just keep harping on that. And I have horror stories to tell you that I've been in doctor's offices where that has happened and the patient just wasn't getting any better. She just kept being brought back in and being yelled at for not eating right. And actually she was injecting insulin, but she wasn't getting any of it because she was doing it wrong and nobody stopped to figure out that she was doing it wrong. So anyway, that would be another story for another day. Okay, so I'm done with my major thing. I'm happy to discuss anything, write down anything. And yes, Lori, I see Lori's note. And Regina, can you type in the chat to Lori my phone number?
Yes, I can. I have to look it up.
Okay, I could just tell it to you. Oh, I see. She sent it. I'm afraid I'm gonna lose this number. So
I got it.
you got it?
Yeah.
Okay.
You want me to send it to her or to everybody?
Send it to everybody. So if anybody wants to yell at me for this presentation, you can do that. Or if you want to charter a plane and send me around the US doing these kind of talks, I'm happy to do that as well. See, that's my dream job after retirement. Somebody just hire me to go talk to people. Okay. So I'm done. And Regina, I don't know if you wanted to do anything or if there's any other questions.
Well, I did want to ask what topics that you all would be interested in learning about next. Next month's topic will be about health disparities and the impact of systemic racism. I know that's been in the media a lot. So, and I know a lot of our Appalachian states may not have a large percentage of minorities, especially the higher up you go, but our southern states do. So I just wanted to hear your perspectives about working with minorities and the impacts of health disparities, whether it's diabetes, heart disease, chronic conditions, and what that looks like in your particular county. So we'll talk about that in August, and I'll be the guest speaker or the facilitator. So that will be coming up in August. Any other topics or discussions you would like to hear more about, we can absolutely put them in the rotation. No. Now, does anyone have any updates about new programs that they've been able to do or new ways of reaching their consumers or participants through virtual or distance learning? Any updates from anybody? You know, school's about to start back. There's a lot of conversation about what that may look like if you work with schools as far as school physical activities. If you have any thoughts or plans about how to work with your schools going forward, especially if they're only doing distance learning or they're doing a two-day, three-day. We have some schools here in North Carolina. Some students are going 3 days on, 2 days off, something like that. So.
Estill County, well, actually, where I work, Interfaith Wellness Ministry, and we're part of the Diabetes Coalition, we're doing something right now for the kids in public housing. We always do a July dental health thing where I normally show them a film and things. So this year with the distance learning or the social distancing, we decided to do a coloring book, and we always give out toothbrushes and toothpaste to the kids at housing. And so this year we're also working on making some cloth masks for that group of kids too.
Okay, that sounds fun. And so I'm assuming they're smaller kid size. Are they the kind that they can decorate, or they're already?
It's just like a little workbook with some coloring pages that has information about, how to brush your teeth properly, how often to brush, when to floss, how often to see the dentist, things like that. Okay. Great. Thank you for sharing. And then what will you disseminate that to the schools or that's going out to the housing community? That's basically for our group at the housing. It's about 100 kids at one of the housing locations or the public housing in our county. Okay. And will they just go to the office and get them, or will they come to a certain specific location to pick them up? No, we actually make up a little bag with the toothbrush, toothpaste, and the information in it and take it to the housing authority. And so the director at the housing authority takes it around to the kids, or the families pick it up when they come into the office, to pay their rent or do something in the office. Okay. Okay, great. Thank you. Any other updates?
I have I guess a question more than anything. In our coalition, of course, with everything, nobody's been able to meet in person and all that. And so the extension and the coalition, some of the things we've done is like we've worked with the farmers market because a lot of people are not going to that. They're just afraid to get out or whatever. But we've been using that, like when they have excess and stuff, purchasing that, putting it to the food pantry. And that's went over real well. It's been helpful, I think, to a lot of folks. But one of the things in my question is we want to do something. And so we're looking at doing maybe a virtual 5K. And so has anybody done that? I mean, how did y'all go about it if you did? I know there's like the Kentucky Cancer Society, or maybe just I'm not sure exactly who it is doing it, but they're doing like a heart walk. And so theirs is virtual, but I didn't know if y'all had any experience with that, doing anything like that.
I do know of an app you can use. It has a leaderboard on it. It's called Move Spring, but it's not a free app. There is a small, I'm not saying it's small. When we got a cost estimate, it was pretty significant, but they may have changed. It's worth research. It's called Move Spring, and they have a free version called Stride Kick, which you can only have up to 10 people. I use that with my DPP class, and it's free to sign up, and it connects to your phone. So it works with Apple and Androids, or if you have any type of smart device where it can track your minutes. And on the leaderboard, you can see how many steps people walk, how many minutes people walk. So it's kind of like tracking your minutes every day, and you can set when it starts and when it ends. So if you want it to be for 1 day, or if you want it to be for, right now we're doing a 21-day challenge. So it just lasts for 21 days. So people can see where they are, and they can either increase their level of physical activity if they want to be in the top 5. I give a gift card a gift card for the top 2 every week. So it motivates them to get in their minutes of physical activity. But that's the only app that I'm aware of. We've had some other coalitions do virtual, they've done virtual walks, not necessarily a 5K, where they're using spreadsheets, and they have small groups to track how many miles they walk over a specific length of time. So does anyone have any experience with virtual 5Ks? That's certainly something we can ask the entire network if anyone has any experience with the virtual 5Ks.
Hey, Regina, this is Janet. Also, we are thinking about trying to do maybe like a Cooking Matters class virtually too. Has anybody had any experience doing that?
No, but I do have access to the curriculum to do it virtually. I could pull it and send it to you.
That would be great.
Regina, could you send it to Sue also?
Yes.
Beth?
Oh,
Deborah Cox, I need that too, please.
okay.
Everybody.
You're just gonna send that out to everybody. I get messages from Share Our Strength. They're the organization that created it, and they've been sending a lot of material out about how to implement that program virtually. So I will definitely do that. And is that the cooking portion or at the store portion? Because they have 2 different curriculums.
The store portion would be good too.
Yeah, we would do both.
Both would be great.
Janet and I.
I'd like
Both.
both.
Me too.
Both, Regina.
Okay, got it.
Include Malika on it, but you're going to anyway, right?
Yes.
So Regina, have you done it before, or have you done the like Cooking Matters or shopping from virtually?
I've only done it in person before.
Okay, that's what we have, and we just, well, it's a learning curve, we're just trying to figure it out.
Yes. But
The
I was
whole
certainly,
world is in a learning curve right now. Did you all see that advertisement on TV that they're advertising either Iceland or Greenland? I can't remember which, but it's, if you want a good vacation, go there and you can scream really loud that 2020 sucks.
Yes, it's Iceland. I've seen that. Yes.
and then we had a question from Faye. She wanted to hear about how others are doing their farmers markets. Is that Sharon? That's Sharon. Sharon asked that question. How people are working with their farmers markets due to COVID-19. Are they open? What protocols are being used?
On our farmers market that we've been doing, they have been, like initially they started just doing the drive-in, and they'd tell them what they wanted, and they done it that way. They didn't get out of their car, and so that kind of helped. But I think it's kind of dissolved from now, and they're just not having as many people, but it just goes back and forth. So
okay.
There's a small cooperative here in Tuskegee, and they have developed a phone list. So every week I get a text on what produce will be available. So you text in your order. There's a $10 minimum, and then you drive to the farmer's market, and then they have it ready for you, and you're paying through Cash App.
Wow.
Okay, that's really innovative. I like the text in your order and the minimum required.
Mhm.
Then you know what they have. Typically, when you go, you don't know what they have until you go.
Get
So you're
there.
pre-ordering. Yeah, you're pre-ordering. Yeah. Oh, we can't hear you, Sharon. I think you're still muted.
Okay. Hey, I'm sorry. Faith, is that information sent out in the newspaper, or you guys just have a list of clientele that you automatically send to?
Well, so I'm actually one of the customers, so I'm just on their distribution list. But you know, I'll reach out to them. I really will. I'll reach out to them because it's a small group of maybe about 3 or 4 farmers, but the things that are coming in season, and it's more efficient now. Because they tried to do it before, but you know, things evolve and efficiencies evolve. And so now I get a weekly text message. I have 48 hours to respond and place my order and punch it in Cash App. And then I drive to the curb market and it's ready for me.
I'll give you a call just because I got a few more questions and I want to take up much time, but I'll give you a call for just a few more details that I would like.
Okay.
Thank you.
Mm-hmm.
Great idea.
Mm-hmm.
Oh, but now that's not my idea. I'm just sharing it because I'm a customer.
But you shared it, and that's the important thing.
Yes.
I will share this, Regina. When I talked with Nell and Sheila the other day, we just completed the DEEP program virtually. We started out face-to-face, but we were in the middle of when COVID happened. And so we ended up having to do the remaining courses or sessions, that is, by Zoom. And so the extension team and 2 outside and RD and myself, we finished that course up. So it can be done. For those that want to do DEEP, it takes a little planning, but it can be done virtually.
Okay, and how was participation? Did you get the same number of participants to come back?
Well, actually, we got, from this county, we had fewer participation because of technology here in the county. But overall, since we opened it up statewide to anyone that want to participate, overall, it was well received. But just counties that actually had coalition, I think Randolph is another one of the coalition counties, they had a greater participation than what they expected. So it's just kind of like I guess you can say an up and down curve. Where there's great infrastructure for technology, it's good. Where there's not so good, you're not going to have that greater participation.
Okay, thank you.
So can I share one other thing?
Yes.
I'm participating now in and same thing happened, what Sharon was talking about, going into the virtual space. And so some of the participation is dropped off, but what has kept us engaged is GroupMe, because we're now at the monthly engagement, and you know, it went from 10 to 5 to about 3, but GroupMe is still, and so that's just helped us stay connected.
Okay. And I've used GroupMe before. It's a texting app. If you have people that can text, it's great. All right, and our time is just about up. And anyone have any other questions or comments they would like to share? This webinar, this virtual office hours, is being recorded, and it will be available on YouTube if you want to share it with any of your coalition members or community members. If you think there's any information that would be beneficial to them, which is certainly possible because Nell gave an excellent presentation about overcoming the fear of injectables. So it's something we all need to be aware of to help change the stigma around insulin injectables. Absolutely.
And GLP-1 injectables.
And GLP-1 injectables. Keep me straight.
That's right.
All right, well, we appreciate you all for taking the time out of your morning/afternoon, depending on which time zone you're in. And we thank you as always for participating. And our next virtual office hours will be on the 4th Wednesday in August, the same time, 11 a.m. Central, 12 p.m. Eastern Standard Time. And if you have any questions, please feel free to call Nell or I, and we'll be happy to help you in any way that we can. Our phone numbers were posted in the chat box. You can always visit our website if you're looking for I guess I can put our email addresses in there if you'd like to email us as well. And if no one else has anything else, enjoy the rest of your afternoon and the rest of your week, and be blessed.
And stay cool.
And stay cool.
For the love of Pete.
You too.
That old
Thanks,
Pete.
Thanks. See you, everybody.
Bye.
I'm also
thanks.
putting Kevin's information in here. If you have any technology questions as well.
Just don't make him move because he broke his foot.
Oh.
I think I didn't put the right email address for myself. I'm gonna get that email address right one day.
That doesn't look right either, but oh well.
Yeah.
So
All right,
type blocks and see what happens.
Thanks.
Don't hang up
You're
yet,
welcome,
Regina.
Sue.
People are still writing it down.
Okay,
So which email is right for you?
it's the. I think it's Knox R. I really do. I think it's.
I think so too. Knox
I
R.
can tell you in a minute.
I think it's Knox R at Marshall.edu.
It is. That's what I have on my phone from your email yesterday.
Okay, great.
Yep, Knox R.
Mercy, mercy.
I have like 4 email addresses. And they all have like the same format. It's like my name, my initials, R Knox, Knox R. Yeah, Knox Regina.
This is Nell.
Thank you.
You're welcome, Sue. Always a pleasure to have you.
Well, we'll see you guys next month, hopefully.